Should we be starting two powerful kidney-protecting drugs at the same time instead of one after the other? That's the question that could revolutionize how we treat diabetic kidney disease, and the Confidence trial just gave us some surprising answers. I'm here to break down what this groundbreaking New England Journal of Medicine study really means for your practice. Welcome back to Medical Journal Club. Today we're diving deep into one of the most clinically relevant trials of 2025. If you're treating patients with diabetes and kidney disease, and let's face it, who isn't, then you need to know about this study. Let's start with the problem we're all facing in clinic. Diabetic kidney disease affects hundreds of millions of people globally. These patients are sitting on a ticking time bomb. They have a dramatically high risk of kidney failure and cardiovascular events. And here's the frustrating part. Even with our current best treatments, we're still not doing enough. Current guidelines recommend multiple protective agents, ACE inhibitors, SGLT2 inhibitors, and now Finerenone. But there's this massive practice gap. Do we start them sequentially, waiting months between each addition, or should we hit hard and fast with combination therapy from day one? The problem with sequential therapy is something every clinician knows too well: clinical inertia. You start one drug, plan to reassess in 3 months, but life gets busy, follow-ups get delayed, and suddenly your patient has been undertreated for half a year. Before we dive into the trial, let's quickly review Finerenone. This is a non-steroidal mineralocorticoid receptor antagonist, essentially a more selective cousin of spironolactone that reduces inflammation and fibrosis in both the kidneys and heart. The Fidelio and Figaro trials already showed us that Finerenone works brilliantly on its own. It lowers albuminuria, slows CKD progression, and reduces cardiovascular risk. The main concern? Hyperkalemia, elevated potassium levels that can be dangerous. Here's where it gets interesting. When you combine Finerenone with SGLT2 inhibitors like Empagliflozin, the SGLT2 inhibitor actually appears to protect against hyperkalemia. This observation led researchers to wonder, could combination therapy be not just more effective, but actually safer? And that brings us to the core research question that's been keeping nephrologists up at night. Does simultaneous initiation of Finerenone and Empagliflozin reduce albuminuria more than monotherapy? This might seem like a simple question, but it's actually revolutionary. We're not just asking whether the drugs work together. We're asking whether we should completely change our approach to treating diabetic kidney disease. The Confidence trial was designed as a rigorous, double-blind, active controlled randomized trial. Notice I said active controlled. This wasn't a placebo study. All 3 arms got active treatment, which makes the results much more clinically meaningful. They enrolled 800 participants across 3 continents, Asia, Europe, and North America. This diversity is crucial for generalizability. The inclusion criteria were tight: CKD with eGFR between 30-90, albuminuria between 105,000, type 2 diabetes, and already on ACE inhibitor or ARB therapy for more than a month. The duration was 6 months of treatment, followed by 1 month of follow-up after stopping. Some of you might be thinking, only 6 months? And we'll discuss whether that's a limitation later. Here's what makes this study population so representative of your clinic. The average participant was 66 years old, 25% female, with reasonably controlled diabetes, HbA1c of 7.3%. About 40% were on insulin, 23% on GLP-1 receptor agonists. This isn't some highly selected research population. These are the patients you see every day. The randomization was elegant: 1:1:1 ratio to Finerenone alone, Empagliflozin alone, or the combination. The doses were clinically relevant: Empagliflozin 10 milligrams daily, and Finerenone 10 to 20 milligrams depending on kidney function. This dose adjustment approach mirrors real-world prescribing. Now let's talk endpoints. The primary outcome was the change in urinary albumin to creatinine ratio at 6 months. For those wondering why albuminuria and not hard clinical outcomes, here's the reality. To show differences in kidney failure or death, you'd need tens of thousands of patients followed for years. It's simply not feasible. But here's the key. Multiple meta-analyses have validated albuminuria reduction as a surrogate endpoint. A 30% reduction in albuminuria predicts about a 27% reduction in composite kidney endpoints. So while it's a surrogate, it's a well-validated one. Secondary outcomes included adverse events, particularly acute kidney injury and hyperkalemia, the safety signals we're most worried about with this combination. The results were striking. Let's walk through these numbers because they matter for your patients. The combination therapy achieved a least squares mean ratio of 0.48, meaning albuminuria was reduced by 52% from baseline. Compare that to monotherapy. Finerenone alone achieved 0.68, 32% reduction, and empagliflozin alone achieved 0.71, 29% reduction. The combination was statistically superior to both, 29% better than finerenone alone and 32% better than empagliflozin alone, with p-values less than 0.001. What's fascinating is that this appears to be a truly additive effect. If you add 32% plus 29%, you get 61%, pretty close to the observed 52%. This suggests the drugs are working through complementary mechanisms without interference. Here's where it gets clinically exciting. Looking at the categorical outcomes, 70% of patients on combination therapy achieved the ADA recommended target of greater than 30% albuminuria reduction. Compare that to only about 52% on either monotherapy. The effects kicked in fast. Within 14 days, the combination group was already seeing more than 30% reduction, and by 90 days, they were hitting 40% reduction. This rapid onset matters because it means you'll know if the treatment is working relatively quickly. But here's the concerning part. When they stopped the medications at 6 months, the albuminuria started climbing back up. While it remained below baseline, this reversibility raises questions about long-term adherence and what happens if patients have to stop treatment. Let's talk safety, because this is where the rubber meets the road. The overall adverse event rates were remarkably similar across all groups, around 50 to 53%. This is reassuring and suggests that combination therapy isn't significantly increasing overall side effects. But drilling down into the specifics, the combination therapy group had a higher rate of eGFR decline greater than 30% at 1 month, 6.3% compared to 3.8% for finerenone and only 1.1% for empagliflozin. However, this appeared to be largely reversible after discontinuation. Here's the surprising finding. Hyperkalemia rates were actually lower in the combination group, 15.3% compared to finerenone alone, 18.6%. This supports the hypothesis that SGLT2 inhibitors protect against hyperkalemia. Let's critically evaluate this trial. The methodological rigor is impressive. The double-blind design with matching placebos eliminates bias. The statistical methods were appropriate, including adjustment for multiple comparisons. Most importantly, they had a 90% completion rate, which is outstanding for a clinical trial. The clinical relevance is undeniable. This addresses a real practice question that nephrologists and endocrinologists face daily. The diverse international population enhances generalizability, and the comprehensive safety monitoring gives us confidence in the risk-benefit profile. Perhaps most importantly, this is the first trial to test simultaneous initiation. Previous evidence was all post-hoc analyses from trials where drugs were added sequentially. This gives us prospective, randomized evidence for combination therapy. But let's be honest about the limitations. First, this is a surrogate endpoint study. While albuminuria is a validated surrogate, some patients and colleagues will want to see hard clinical outcomes: kidney failure, dialysis, death. We don't have that data, and we may never get it because such a trial would be prohibitively large. The short 6-month duration is concerning, especially given that the effects largely reversed after discontinuation. This raises questions about the durability of benefit and what happens with longer-term treatment. The industry sponsorship by Bayer is another consideration. While the trial appears methodologically sound, industry-sponsored trials have historically shown bias toward favorable outcomes. Finally, the higher rate of acute kidney injury with combination therapy, even if reversible, is something that will make clinicians nervous. Despite these limitations, this trial supports a fundamental shift in our approach. Instead of the traditional stepwise escalation, we're looking at simultaneous initiation of combination therapy. This could dramatically reduce clinical inertia, that frustrating phenomenon where patients remain undertreated for months because we're waiting to see how they respond to the first drug. The trial provides strong rationale for combination therapy and will likely influence future guidelines. Major nephrology and diabetes organizations are already incorporating these concepts into their recommendations. But here's the key question: should we change practice based on surrogate endpoints alone? That's a philosophical and practical question each clinician needs to answer. So where does this leave us? The confidence trial demonstrates that combination Finerenone plus Empagliflozin achieves superior short-term albuminuria reduction compared to either drug alone. The safety profile is acceptable, though it requires monitoring. However, we still need longer-term outcome trials to prove clinical benefit. The reversibility of effects after discontinuation is concerning and highlights the importance of adherence. For your clinical practice, this study provides evidence-based support for combination therapy in appropriate patients. It suggests we can safely initiate both drugs simultaneously in patients with diabetic kidney disease who are already on ACE inhibitors or ARBs. The bigger picture? We may be entering a new age of combination therapies for chronic kidney disease, moving beyond the traditional one drug at a time approach. This aligns with how we already treat heart failure, hypertension, and HIV, conditions where combination therapy is now standard. Drop your thoughts and questions in the comments below. If you found this analysis valuable, don't forget to like, subscribe, and turn on notifications for more evidence-based critiques. Your engagement helps us reach more medical minds worldwide.